So I think now we'll go back to Dr. Martin.
So, thank you. So I promise the last time now. Then I'm done. Could you run the slides, please? Excellent. So when I saw the topic they gave me, I was thinking there's a question mark missing. And in the program, there's this question mark not there. So it's never too late for laser vision correction in presbyopia. I'm not sure. I put a question mark, okay? So if you look at the prevalence of presbyopia, so since population is aging, the predicted prevalence based on demographic data in the European Union in 2050 is 83%. That's massive. Now we have 280 million people who are presbyopic in the European Union and 1.8 billion globally. So just to make this problem more, and put it more into focus. If you look it up in PubMed and put presbyopia correction, you see that there are almost 1,000 papers published about presbyopia correction. So it's a hot topic, so to speak. Of course, I go quickly through the non-surgical options of presbyopia corrections. I just put your focus on the pharmacological approach. I don't have any experience with this VOD eye drops. But apparently they work somehow, and there's an approach which is called crystalline lens softening, which may want to restore accommodation based on pharmacological techniques. What are the surgical options? Of course, laser vision correction, either monovision or advanced presbyopia profiles. We go into detail a little bit later. Refractive lens exchange or cataract surgery. Crystalline lens softening. There's this laser from the company of Roviac, which is able to soften the lens, but we're still waiting for clinical data. I heard about this laser, I think, almost 10 years, but apparently they have some major problems. Restoring dynamics is one of these approaches, so accommodating IOLs, sclera expansion or electric stimulations. They are nice and interesting projects going on. Corneal inlays. I put in a different color because I'm not sure if anyone here is still using corneal inlays to treat presbyopia. And as we saw right now, the conductive keratoplasty, I think, is also not very common anymore. It's too late for laser vision correction if, of course, significant cataract, we have to deal with significant cataract. And if there are contraindications for laser vision corrections, like high ametropia, corneal diseases, etc. So if you talk about presbyopia laser correction, there are basically two ways or two options. So on the one side, it's the monovision, so the classic monovision can achieve with excimer laser treatment, with SMILE, and there are modified ablation profiles, multifocal profiles, or increased depth of focus monovision, so a better monovision, so to speak. So laser monovision, interestingly, the first paper was pretty late. It was 1999 that someone published a PRK in monovision. The trend now is that you achieve less anisometropia, but more depth of focus. It's more or less based on a controlled induction of spherical aberration. There are many studies published already. We recently were very happy to publish the first study about SMILE and monovision, and I'll go quickly through. I already mentioned some advantages of SMILE. And we showed in this paper that 84% showed no need for reading glasses with uncompromised, uncorrected distance visual acuity. So this was a pretty good result. So we were happy with that, and comparable to, of course, other techniques. So if we talk about modified ablation profiles in terms of presbyopia correction, there are different approaches. Combining increased depth of focus and monovision, for example, Presbyon from SMILE, or custom Q algorithm from Wavelight Alcon. There are multifocal ablation patterns with near and distance vision zones. Transitional multifocal patterns, peripheral near vision multifocal, central near vision multifocal patterns. I don't think these are very popular anymore. So the most popular ones are certainly the one on top, and here the hybrid techniques. So Supercurve from Bausch & Lomb and PresbyoMax from Schwind. Laser blended vision from Zeiss. I think probably the most studies of presbyopial laser vision correction published are based on this technique. It's a non-linear aspheric monovision ablation. So the idea is to induce a controlled amount of spherical aberration in both eyes, increase the depth of field, and make the non-dominant eye slightly myopic, up to -1.5. It's very important to check this precompensation factor for the induction of spherical aberration. So there are limits, of course. So there are anatomical limits, there are limits for the intended correction, the age, the tolerance, and you have to keep in mind that you could not just put a desired amount of spherical aberration into your machine. Probably you induce topographically central islands. The studies are pretty good, but to be honest, it's 3 out of 4 studies are from Dan Reinstein's group. Not that he's not doing a great job, but of course this is all from one scientific group. So just to mention that, the custom Q algorithm from Wavelight is based on a corneal asphericity modulation. So again, changing spherical aberration. So the idea is to induce a control amount of negative asphericity in the non-dominant eye. The dominant eye is corrected for distance as usual. So you create a kind of hyperproletnesis. The published data is also very nice, very good results in uncorrected near and distance visual acuity. But before we go on, the studies are very inhomogeneous. So it's very hard to compare the studies, myopic, hyperopic, ametropic. So this is all together. So it's very hard to find a good comparison. The Supercurve from Technolas is a little bit different. Sorry for this cropping thing here. We couldn't handle that. So in this ablation profile, both eyes are targeted -0.5. Theoretically, leads to a near addition of 2.0 diopters. The studies or the data is not that good as in the others. As you see here, for example, binocular uncorrected distance visual acuity of 20/25 or better in 36%. It's pretty low. I'm not sure what happens here, but so probably we need more studies for this. PresbyoMax from Schwind, again, this is a hybrid technique, so some kind of multifocality, some kind of induction of spherical aberration. All these profiles are kind of a black box. You don't know really what they are doing, so you really have to trust them. It's based on that you create a hyperpositive shape with an addition of between 0.75 up to 2.5 diopters. There's no difference between the dominant and the non-dominant eye, although you could do that. You can do a micromonovision, for example, and the studies are, again, very inhomogeneous. So some did monovision, some not. However, the results are pretty promising. So the challenges in treating presbyopia is that there's a lot of theory, and the challenge is the theoretical amount of change in spherical aberration to achieve reading without compromising the distance vision. So because all the people don't want to lose distance vision. So another challenge is the required change versus the achieved change in spherical aberration. So there's a lot of theory. The limits, of course, the LASIK limits, the accurate target refraction is absolutely crucial, of course. What about touch-up procedures in these profiles? So there are a lot of questions still to ask, and of course the expectation of the patients is a very demanding group of people. I can go through this complication very quickly. I just want to point out that the neuroprocessing period probably takes longer than we used to. So these are very complex profiles. The age, the older you get, the slower the neuroprocessing period is, or the period time is. So keep that in mind. So in summary, modified ablation profiles deliver good and safe results, no question about that. But there are new opportunities, particularly for hyperopes and ametropic patients. The studies are very inhomogeneous, and consider the limits, set realistic expectations to the patients, not the laser treat all your problems. So really tell the patient they might need reading glasses and so on. And again, under promise, over deliver. In this question, I think it's very helpful. Thank you.
Thank you, Dr. Martin.